Good morning, everyone, and welcome to the University of Louisville Department of Medicine Grand Rounds. I'm Dr. Kelmenson Williams, and I'm the Chief of Medicine here, and it's my pleasure to introduce our Pulmonary Division's guest speaker from University of Alabama, Dr. Daniel Kelmenson, and he is the Assistant Medical Director at the Medical Intensive Care Unit and Assistant Professor of Medicine. And he's going to speak on ARDS. And before I introduce him completely, I'm going to introduce, as I normally do, our introducer, and that is our own Associate Professor of Medicine, Dr. Umair Gauhar. He is actually spent a lot of time at University of Alabama, Birmingham, and he is now an Associate Professor in the Division of Pulmonary Allergy and Critical Care Medicine here at University of Louisville. Dr. Gauhar?
Thank you, Dr. Williams. Good morning, everyone. Today we have Dr. Daniel Kelmenson with us from University of Alabama, Birmingham, and he is the Assistant Professor of Medicine with the Division of Pulmonary Allergy and Critical Care Medicine at UAB. Dr. Kelmenson did his internal medicine training at Massachusetts General Hospital, followed by a fellowship in Pulmonary and Critical Care Medicine at University of Colorado. He then joined UAB in 2018, where his area of interest is in critical care medicine. Dr. Kelmenson holds a lot of leadership positions at UAB, including the medical and quality officer for the Department of Medicine. He's also the medical director for the Rapid Response and Medical Emergency Team, and the chair of the Resuscitation Committee, and he's also the chair of the COVID-19 Treatment Committee. And today he's going to talk to us about a very important topic that all of us have come to recognize, especially in the last 2 years or so, in the ICUs and outside the ICUs. He's going to talk to us about ARDS, diagnosis, treatment, and mimickers. So we're looking forward to your talk, Dr. Kelmenson. Thank you very much.
Great. Thank you for the introduction. Thank you for having me as well. Hopefully you should be seeing my slideshow. If not, feel free to interrupt me.
Doing well.
Perfect. All right. Zoom 101 here. Still got it. So I'll be talking to you about ARDS, the diagnosis, treatment, and mimickers. This will be relevant both for the ICU, where I primarily work, and also on the wards, where a lot of patients with ARDS exist, both in COVID times and without. Coming to you from UAB, and once again, appreciate y'all having me. So we'll start with the case here. A 23-year-old woman presents to the emergency room with shortness of breath. She's afebrile, tachycardic, normotensive, tachypnic, and hypoxemic. On exam, she's in obvious respiratory distress. She becomes more hypoxemic in the emergency room, and on ABG on 100%, 50 liters of high flow nasal cannula, her pH is 7.25, her CO2 is 44, and her PO2 is 67. The questions we're going to answer for her today, after looking at her X-ray, which shows bilateral alveolar infiltrates, and her CAT scan, which shows bilateral ground glass with consolidation at the left base. And the questions we want to know are, what is this condition? What caused it? Workup, and management. So we'll go through the talk. I won't use the whole time, so feel free to type questions in the chat or ask them at the end, and then we'll come back to the case at the end. So ARDS, or acute respiratory distress syndrome, is an inflammatory lung injury where fluid leaks into the interstitium and the alveoli. This would be some classic histopathology here with inflammatory cells, and these hyaline membranes forming inside the walls of the alveoli, formed by proteinaceous exudative fluid. And ARDS is sort of like diagnosing iron deficiency anemia, and that you're not done. It's a syndrome. It's not really a specific diagnosis. So you still need to figure out what's causing it, much like you would figure out if a GI bleed is causing iron deficiency anemia. And if you have not figured out what's causing it, you need to really think to yourself, is this actually a condition that looks like ARDS, but is not ARDS? Is this a mimicking condition? And we'll go through a lot of those during the talk. So this will be the wordiest slide. This is the definition of ARDS from the Berlin criteria from the conference where they devised this. And it's going to go ARDS. So A is acute. So the respiratory symptoms have to have begun within a week of a known clinical insult, or the patient must have new or worsening symptoms during the past week. So if you have a patient with 3 months of progressive shortness of breath presenting to you in the clinic or in the emergency room, that is not ARDS, that is some other condition. It has to be a truly acute process. It's a respiratory process, so there has to be actual opacities inside both lungs on a chest X-ray or CAT scan. And these opacities can't be explained by something outside the lung, like a pleural effusion, cannot be explained by collapse of part of the lung, collapse of the entire lung, or pulmonary nodules. It needs to be respiratory infiltrates inside the lungs. The patient has to be in distress, the D, so it's hypoxemia. This is classically measured with an arterial blood gas, where the ratio of arterial oxygen tension to fraction of inspired oxygen is less than 300, measured with a PEEP of at least 5. And we're going to go over a lot of these P to F ratios when we look at some of the trial data. The FiO2 is a decimal, so 100% is 1 or 50% is 0.5, and the PaO2 is straight off the ABG. And finally, it's a respiratory syndrome, not a cardiac syndrome. So the respiratory failure cannot be fully explained by cardiac failure or fluid overload. And if you have no risk factors for ARDS, then you need some sort of objective assessment, usually an echo, to exclude hydrostatic pulmonary edema, to make sure you're not confusing cardiogenic pulmonary edema, heart failure, for non-cardiogenic pulmonary edema, ARDS. And notably, this is often thought of as an ICU disease. Obviously, I see a lot of it and saw a lot of it the last couple of years, but it's present on the floor as well. If you have a patient come to you with 3 days of fever, cough, dyspnea, they have a pneumococcal antigen that's positive in their urine, bilateral infiltrates on X-ray, they're placed on CPAP for workup breathing, 5 a PEEP, 30% FiO2, and their ABG is 7.38 for the pH, 41 for the CO2, 82 for the PO2. That patient has ARDS. Now, they may have mild ARDS based on their P to F ratio, but it's still below 300. And that patient has ARDS and certainly has potential to worsen. So the chest X-ray for ARDS can vary. It's a syndrome. It can vary from mild to moderate to severe based on the degree of oxygenation. This would probably be a severe ARDS with bilateral alveolar infiltrates. Your CAT scan, once again, needs to have bilateral infiltrates based on the Berlin definition, but will often be a combination of ground glass and consolidation. As we'll come back to later when we talk about proning, you'll see that the infiltrates can often be worse at the base of the lungs. Here, there's more consolidation at the base of the lungs where you cannot see the lung architecture anymore. There's more ground glass anteriorly and a little bit of normal lung. Obligatory cartoon for a PowerPoint. So risk factors for ARDS. The biggest one I see, I work primarily in the medical ICU, is sepsis. Direct sterile aspiration can produce ARDS as well, or pneumonia. And then other causes of ARDS that are less common, but that you may see more commonly depending on where you work, includes trauma, which could be peripheral to the lungs, or direct pulmonary contusion. Transfusions or trolley, transfusion-related acute lung injury can do it. Pancreatitis would be a classic inflammatory cause of ARDS, and direct smoke inhalation. Sometimes you'll see this develop after a house fire or something like that. What I want to spend some time on is conditions that look like ARDS but are not ARDS. So these are mimicking conditions of ARDS. And these can present exactly the same way as true ARDS from a pneumonia. You can have the same history, same time course, the same exam, the same initial set of labs, the same chest X-ray, and the same CAT scan. So sometimes you gotta dig a little bit deeper to find these through some additional diagnostic tests if you don't have a clear cause of ARDS. So the mimickers we'll look at are heart failure, diffuse alveolar hemorrhage, acute eosinophilic pneumonia, organizing pneumonia, acute hypersensitivity pneumonitis, and acute interstitial pneumonitis. We'll spend one slide at each. The most common mimicker by far is going to be heart failure. I will not talk about heart failure extensively during this presentation, but obviously it can be ischemic or non-ischemic in etiology. Sometimes heart failure, unlike some of the other mimickers of ARDS, you'll pick up more on exam in terms of volume overload, JVP, the normal things you look for. And most patients with ARDS are going to have some sort of screen to make sure you're not actually dealing with cardiogenic edema from heart failure. A lot of these patients merit a BNP or pro-BNP, and usually they're going to get an echo. If you have the skills, point of care ultrasound may be fine, but by the time they come to me in the ICU and they're sick and they're intubated, most of them are going to merit an echocardiogram. They've certainly had plenty of cases in my relatively short career where something that was thought to be ARDS turned out to be cardiogenic pulmonary edema, and the ARDS disappeared with 20 liters of diuresis. Diffuse alveolar hemorrhage is another mimicking condition of ARDS. So when I'm rounding with residents and medical students and we get an X-ray with acute bilateral infiltrates in a patient that's been sick for only a few days, the three liquids I tell them to think about are pus, blood, and fluid. Pus for pneumonia, the fluid for heart failure or ARDS, and this is the blood for diffuse alveolar hemorrhage. Etiologies of this, we often think of DAH as caused by an interesting condition like encapsulitis causing a capillaritis, but this can also be bland hemorrhage in the setting of coagulopathy or thrombocytopenia. It can also be caused by diffuse alveolar damage, where a patient has an inflammatory injury to the lungs, and that leads to bleeding. And this is diagnosed by bronchoscopy, where you do bronchoalveolar lavage, or BAL, with serial lavages. So I go into the lungs with a bronchoscope. I sort of wedge the bronchoscope, which means I put the bronchoscope as far I can into the airways where I can go no farther, trying to do it in a region of the lung that has a lot of evidence of disease on imaging. I kind of shoot saline down the bronchoscope into the lungs, suck it back up, get a new syringe of saline, do the same thing, get another new syringe of saline, do the same thing. These are serial lavages of saline. And the idea behind diffuse alveolar hemorrhage is the bleeding is coming from the alveoli, as in the name. This is different from someone with epistaxis, where they might be aspirating blood into their lungs from the nose. So what happens here is if the blood is coming from the alveoli, as I insert serial aliquots of saline and then remove each one back into the syringe, you'll get increasing return from the alveoli as each aliquot goes in. And since you're getting return from the alveoli more and more each time, your return will get bloodier and bloodier if it's alveolar hemorrhage. And you get the appearance of these syringes where you go from a not particularly bloody return to a more red, bloody return. This is different from something like epistaxis, where since the blood is aspirated into the lungs, but is really coming from the nose, when you do these serial returns, you're actually diluting out the blood in the lungs. So the return may start bloody as you're initially getting the blood from the nose, but as you dilute it out and get more and more of an alveolar sample, your return gets less and less bloody. And this is what it looks like to perform a bronchoalveolar lavage. The bronchoscope comes in here into the airway as distal as possible, usually a third or fourth generation airway. Saline goes in, and then we pull it back or suction it into a trap. And we can send that for both the visual appearance for bleeding and some other tests, as we'll talk about, for some other diseases. So one of those other diseases that can mimic ARDS is acute eosinophilic pneumonia. It can have a number of etiologies, drugs, including some antibiotics that we give in the inpatient setting, infections in the developing world, often thinking about parasitic diseases, and direct smoke inhalation causing toxicity to the lungs. This is also diagnosed by bronchoscopy with BAL, but here you're sending the fluid return from the alveoli to the lab and getting a cell count and differential. What you're looking for is greater than 25% eosinophils to make a diagnosis of eosinophilic pneumonia. The next condition, another mimicking condition of ARDS, is organizing pneumonia. Number of etiologies as well here. Drugs can do it, autoimmune disease, infections, malignancy. And if you don't find an etiology, we call this COP, or cryptogenic organizing pneumonia, formerly known as BOOP. The diagnosis here is you can't really make this with bronchoalveolar lavage. You can't make it with labs. It really needs to be made by biopsy. There's imaging characteristics that could suggest this, but like I said, really all of these conditions can look the same on chest X-ray or CAT scan. You can sometimes make this biopsy by transbronchial biopsy, but we don't tend to perform those a lot when patients get really sick in the hospital because of the risk of pneumothorax, and you're also not getting a lot of tissue. So it sometimes can be hard to make these diagnoses. So the diagnosis is classically made by a VATS, especially once a patient gets to an ICU, video-assisted thoracoscopic surgery. And here you'll see the intraluminal plugs of fibroblastic granulation tissue, helping to diagnose organizing pneumonia. Acute hypersensitivity pneumonitis, we often think of this as a chronic disease. That's its more classic form. But this can present acutely as well. A number of etiologies, birds, which are the historical archenemy of pulmonologists, and I think we're losing the fight over the last few centuries. Birds causing hypersensitivity pneumonitis. many occupational exposures, farmers, various factory workers, but there is a almost uncountable number of etiologies of this, greater than 300 etiologies. And this is where your social history in terms of what the patient does for a living, pets, hobbies, really comes into play in making this diagnosis. The biopsy is also needed to make this diagnosis. Once again, you may be able to get this off a transbronchial biopsy, but you'll get more tissue, and in a sicker patient, we're usually proceeding to VATS biopsy if we suspect this. And then the final mimicking condition of ARDS is acute interstitial pneumonitis. The eponym is Hammond-Rich syndrome. Etiology by definition is idiopathic. This is a condition that looks like ARDS. You have no etiology of ARDS, no sepsis, no trauma, no pancreatitis. And this diagnosis is also only made on biopsy, usually a VATS biopsy. And here we'll see the inflammatory cells as well as fibrosis, diffuse alveolar damage. And this, once again, is going to look like ARDS, but you never find an etiology. So when you're trying to diagnose someone with ARDS, make sure they meet the Berlin criteria. Is it acute? The respiratory infiltrates? Are they in distress with hypoxemia? Is it a confirmed pulmonary and not cardiac syndrome? And your workup should include usually an ABG. Most patients merit that. A microbiology workup, since that's going to be your most common etiology of ARDS. So blood and respiratory cultures, a viral PCR and a COVID PCR. Some kind of heart failure workup. You can be fooled. Sometimes the exam doesn't pick it up. So usually some combination of a BNP, EKG, and an echo, point of care, or formal. And then if you have a diagnosis from the above and you're satisfied, fantastic. You know, their COVID PCR comes back positive, maybe more likely 2 years ago, and you're satisfied with the diagnosis, you can usually stop there. But if you don't have an answer, you need to proceed on with your diagnostic test, because you may be dealing with a mimicking condition that looks like ARDS, that meets the Berlin criteria, but is actually a different disease. So the next step is proceeding to bronchoscopy. And the three main things you're looking for with bronchoscopy are acute eosinophilic pneumonia based on the cell count and diff, bleeding with diffuse alveolar hemorrhage diagnosed visually on serial aliquots of saline, and cultures. Many times this has happened where you may have a patient who you suspect has an infection. The above micro workup is negative, including COVID, and you get a bronch, and their COVID comes back positive on the bronch, or they've got Staph aureus on the bronch, and the patient wasn't coughing up any sputum for you. So sometimes you really only get that answer on bronchoscopy, although we certainly try for a less invasive diagnostic test first. So should you get a VATS biopsy? Most of the time, no. I see a lot of ARDS, and I probably send 1 out of 100 patients for a VATS biopsy. But if it looks like ARDS, you don't have a risk factor for ARDS, you don't have sepsis, pneumonia, etc., you do a bronchoscopy and it's unrevealing for eosinophils or hemorrhage or infection, then the answer is yes, because you may be dealing with a mimicking condition of ARDS that you're only going to diagnose with a biopsy. So normal lung here on the left, here's diffuse alveolar damage with inflammatory cells and hyaline membranes. Then here's cryptogenic organizing pneumonia with those plugs of granulation tissue. These are different diseases, but they all may look the same until you get tissue. So we're already about halfway done here, and we're going to proceed on to talking about some of the evidence for how we manage ARDS. Some of this will be ICU data, some of this will be data from the wards. We're going to look at non-invasive oxygenation strategies and look at one pivotal trial for each of these. So for that, we'll look at the Florally trial in the New England Journal, low tidal volume ventilation, a foundational study for really critical care, the Armist Study, diuresis and fluid restriction from the FACT study, proning from the Prociva study. We'll also look at proning on the wards and non-intubated patients, ECMO from the Eolia study, and then a perpetual controversy, steroids. So there are a number of ways you can oxygenate patients. Nothing revolutionary here. Nasal cannula, face mask, Venturi mask give you more precise oxygenation. For higher oxygen needs, non-breather mask, high flow nasal cannula, CPAP, continuous positive airway pressure, BiPAP, bilevel positive airway pressure, or intubation. And as clinicians, both on the wards and in the ICU, we often want to know what's the best way to oxygenate our patient, especially once they need large amounts of oxygen. And this has been largely unclear. I'm going to present some data from the pre-COVID era from the Florally study, but it's not the final answer on this. So the Florally study, I'd say, is probably the best data we have, although it is not perfect. This is from 2015. It enrolled patients with acute hypoxemia who had a PDEF ratio of less than 300. So once again, FiO2 is measured as a decimal, and FiO2 of 100% is 1. So they had a PaO2 below 300 if they weren't 100% FiO2. And they were not hypercapnic because those are patients you might think about BiPAP for. So their PaCO2 on an ABG was less than 45. There were 3 arms in this study. Control arm got standard non-rebreather face mask. Intervention arm got high flow, 50 liters per minute. And the intervention arm number 2 got BiPAP. And their primary outcome was intubation within 28 days. And it was a negative study. So time on the x-axis here, intubation on the y-axis. There was a trend towards less intubation of the high flow group, but it was not significant. So 38% of high flow patients were intubated within 28 days, 47% of face mask patients, and 50% of BiPAP patients. You can see relatively early separation in the first few days that's maintained, but did not meet significance. So a negative primary outcome, I'm going to do the thing which you're not supposed to do, which I'm going to do again during this talk, is look at secondary outcomes that are positive for a negative primary outcome study. So the high flow group had more ventilator-free days by day 28, 24 days for high flow, 22 days for face mask, and 19 days for BiPAP. They also died less by day 90, 12% for high flow, 23% for face mask, and 28% for BiPAP. So here on the graph, time on the x-axis, survival on the y-axis, early separation in the first couple weeks, and more survival for the high flow group compared to standard oxygen or non-invasive ventilation. But I will say the caveat again, this was a negative study. These are positive secondary outcomes. You want to take it with a very large grain of salt. So maybe high flow is better, but this is not a final answer. So how do I interpret this? This is not a definitively settled issue. There are some studies from COVID that suggested possible benefit of CPAP or BiPAP over high flow, but those were not definitive either. How I practice, and most of my colleagues, we generally use high flow for severe hypoxemia that does not require intubation, but there are a number of situations where BiPAP may be more appropriate. COPD has the strongest data supporting that, especially for COPD exacerbations with hypoxemia and hypercapnia. There's a mortality benefit to using BiPAP. Other conditions, hypercapnia for other reasons. Besides COPD, you want to think about BiPAP to provide additional ventilation to help the patient exhale their CO2. Morbid obesity, obstructive sleep apnea, obesity hypoventilation syndrome are situations where your patient may already be on BiPAP at home at night and may benefit from it in the hospital. And cardiogenic pulmonary edema, we think of that as a classic indication for CPAP or BiPAP. The data there is honestly not as strong as we often think clinically. That's another indication where you may want to use BiPAP. And then this is definitely an ICU study, but this is the foundational study for critical care. So we will talk about it. This is the Armist Study published in 2000. It enrolled patients who had ARDS for less than a day and a half. They were intubated in the same PDEF inclusion criteria as the previous study, below 300. So they did not have to be particularly hypoxemic to be enrolled. The control arm had a tidal volume, which is a breath you get with each delivery from the ventilator, of 12 cc's per kilogram of predicted body weight. Predicted body weight is based on your height and gender. It's not based on your actual body weight. And they had a plateau pressure goal of less than 50. A plateau pressure is measured at the end of an inspiration. The ventilator prevents that breath from being exhaled, and thus there's no airflow, there's no change of resistance, there's no change in pressure. So the pressure the ventilator measures is in theory similar to the pressure inside the lungs at the end of inspiration. That's called a plateau pressure. So getting a sense of the pressure inside the lungs at the end of an inspiration. The intervention arm had a lower tidal volume goal and a lower plateau pressure goal. The primary outcome was mortality. And this worked. Mortality dropped from 40% in the higher tidal volume, higher plateau pressure arm to 31% in the lower tidal volume, lower plateau pressure arm. Very significant p-value. On the graph, time on the x-axis, proportion of patients on the y-axis. These two top curves are survival for the lower tidal volume arm and the higher tidal volume, higher plateau pressure arm. So why does this work? Well, a lot of what we do in critical care, the patient sort of gets better or worse on their own. And a lot of what we do is just supporting the patient through their disease process. And lower tidal volume ventilation supports a patient while injuring them less than a different ventilatory strategy. So lower tidal volume compared to a higher tidal volume is less volume in the lungs with each breath, causing less distension of the lungs, less volume trauma and inflammatory injury from that. A lower plateau pressure goal means less pressure in the lungs at the end of each breath, causing less barotrauma, less inflammatory injury. The idea is we're sort of providing less injurious ventilation with this strategy. And this is what we do for all our ARDS patients. We do these for a lot of non-ARDS patients too, although the data is really there for ARDS. This is a strategy you can do both in the ICU and on the wards. This is the FACT study from 2006. Enrolled patients with ARDS for less than 2 days. They were intubated, although we certainly apply this to non-intubated patients. And they had a PDEF ratio below 300. The control arm had a liberal fluid management protocol, which we'll go over briefly, but that meant essentially more fluid for the patient. The intervention arm had a conservative fluid management protocol. This was another strict protocol that meant less fluid for the patient. The primary outcome was mortality. And like we talked about for the Florally study on oxygenation strategies, this was a negative study. There was no difference in mortality. I'm going to once again do the cardinal sin of looking at secondary outcomes, ventilator-free and ICU-free days. All right, your eyes are about to glaze over. Here's the protocol. There it is. So we're not going to go over it in depth. I just want you to appreciate how complex this protocol was, and thus I think how unrelevant it is to actually taking care of patients. The number of steps they had to decide here for whether to give the patient Lasix or fluid or an inotrope was extensive. They looked at the CVP or the wedge. They looked at the MAP. They looked at the urinary output. They looked at the cardiac index if the patient had a SWAN. They looked at cold scan, mottled scan, capillary refill time. None of them are wrong to use, but I think the number of factors that they used to decide which box the patient fit in terms of whether they got fluids, inotropes, or diuresis is just not reasonable for clinical management. So when we actually applied the results of this trial, recognized they used a protocol that was a lot more complex than I think what we do in clinical care. Once again, negative primary outcome on mortality, but the secondary outcomes were positive. So the conservative strategy, less fluid for the body, increased the number of ventilator-free days by 2.5, and increased the number of ICU-free days by 2.5. So on the graph, time in the x-axis, proportion of patients on the y-axis. Survival curves on top, there were no difference, but on the bottom, breathing without assistance, off the ventilator, early separation with conservative strategy. So with the caveat again that these are positive secondary outcomes for a negative primary outcome study, we do often apply this for our patients. This is sort of the dry lung, happy lung theory is what we tell learners on rounds, in that the patient may have ARDS with primarily non-cardiogenic pulmonary edema, but if there's a component of cardiogenic pulmonary edema, we try to remove it with Lasix and with fluid restriction, with the idea of getting fluid out of the alveoli, improving ventilation perfusion matching, getting the patient off the ventilator quicker, getting the patient out of the ICU quicker. And over the last 10 years, there's been a sea change in critical care. We've really gone away from a lot of the aggressive fluid resuscitation that we did in the past. When I was a resident, which is not that long ago, I mean, we would often give 10+ liters to a patient with sepsis. Those days are largely gone. There's been primarily observational and some randomized studies looking at the harms of fluid overload, both for ARDS patients and for sepsis. And we've gone away from such aggressive fluid resuscitation. So we apply this by, if our patients have ARDS, they're not in significant shock, they're not in significant renal failure, we often try to limit fluid intake and diurese them until they either develop significant shock or develop significant renal failure that we think might be pre-renal in etiology. Now we get to Pronine, my favorite study. This is the Prociva study, almost 10 years old now. Enrolled patients with ARDS for less than 2.5 days, intubated, and this is a sicker population. So the PDEF ratio is less than 150. So at 100% FiO2, the PaO2 is below 150. The control arm got standard of care supine ventilation. The intervention arm was prone for at least 16 hours a day. And the primary outcome again here was mortality within 28 days. This is one of the most dramatic outcomes we've ever had in critical care. Drop mortality from 33% to 16%, so cut it in more than half. Here we'll see time on the x-axis, survival on the y-axis, proning in red, supine in blue, early maintained separation between the groups, dramatic survival benefit with proning. This came on the heels of a number of studies of proning that had shown oxygenation benefits, but not mortality benefits. This study proned patients for longer, was big, and showed a very dramatic mortality benefit. So why does it work? Let's go back and look at that lung for a patient with ARDS. So right lung, left lung, heart, ground glass, ground glass, and consolidation at the left base. You'll see that a lot of the disease is worse in the dependent parts of the lung, where with gravity, they're going to get more blood flow. So you've got poorly ventilated regions that are getting more blood flow than they should get because of gravity. Up here, you've got sort of the baby lung, the remaining good lung that's doing a lot of the work for ventilation. And this lung is not getting as much blood flow as it should get because it's dependent away from gravity. You've also got the heart here, which is sitting and compressing part of the posterior lung. So if we flip this patient, and notably I rotated the image 180 degrees, this is not actually exactly what it'll look like prone. This heart is not just sitting on this very thin bit of tissue. But if you rotate this patient 180 degrees, you prone them, a few things will happen. The heart will eventually come down and settle on the sternum. So it's no longer compressing the lung. It'll actually be sitting on the sternum, on the bones, rather than the lung. The good lung, the baby lung, is now dependent. So it's at the bottom here. And thus, with gravity, it's going to get more blood flow. So you'll get better ventilation, perfusion, matching. And the bad lung, which has ground glass, consolidation, is now no longer dependent. So it won't get as much blood flow. You'll get less blood flow to a poorly ventilated region. You also won't have the heart compressing it anymore. So it'll hopefully open up. So this is kind of why we think proning works, better VQ matching, less compression of the lungs, and seems to have a dramatic mortality benefit. So since the benefit was so good, when COVID came along, people asked, can we do this for non-intubated patients as well? Obviously, the ICUs were full. Lots of patients were very hypoxemic on the floor who probably would have been intubated at different times. So can we do awake prone positioning? And this is a trial that's actually a combination of a number of RCTs that sort of pooled their results. Enrolled patients with COVID and hypoxemia, a PDAF ratio below 300, who were on high flow nasal cannula, and 40% of these patients were not in the ICU. Control arm was supine standard of care oxygenation. The intervention arm was proned as much as possible. You'll remember with the Prociva study, those patients were prone to at least 16 hours a day. Here is just as much as possible. And the median was about 5 hours a day for these awake patients. The primary outcome was treatment failure, a combination of intubation and death within 28 days. And it seemed to work. It lowered the outcome of intubation and death from 46% to 40%, driven primarily by reduced intubation with proning. There was no mortality benefit, unlike Prociva, although these patients also were not dying at the same rate as Prociva, since these were not intubated patients to begin with. On the graph, time on the x-axis, survival without treatment failure on the y-axis, prone group in blue, supine group in red, early separation that's maintained between the groups. And notably, although this was not what the study was explicitly studying, a longer duration of proning was associated with better outcomes, implying that if you prone the patient for longer than 5 hours a day, the longer the better, less likely to be intubated. There's obviously a number of confounders that can affect this, including that, healthier patients, less likely to die, might also be able to prone themselves for longer, may have better mental status and able to prone themselves for longer, etc. So it doesn't mean that there's a perfect duration of proning. Probably if this therapy has benefit, the more the better. In the intubated patients, a lot of the early studies that did not show mortality benefit from proning prone the patients for much less than 16 hours a day. So if this therapy is beneficial, and we believe it is, probably the more the better. So you can do this obviously in the ICU with intubated patients. You can also do this on the wards if your patient has the mental status to prone themselves. It's relatively easy to do. We did this a lot with COVID. We do it a lot less now than we used to as our census has gotten better, but this can certainly be done on the hospital wards for a patient who you suspect has mild ARDS and doesn't yet need the ICU. However, if your patient is the worst of the worst, then you need to think about ECMO. This comes from the UofL study in 2018. These are sort of the sickest patients we have. Patients with ARDS for less than a week, intubated, and these had very severe derangements in either hypoxemia or hypercapnia. So their PDAF ratio was below 50 for 3 hours. 50 means on 100% FiO2, their PaO2 on an ABG would be below 50, or they had a PDAF ratio below 80 for more than 6 hours, or they had a pH below 7.25 with a CO2 above 60 for more than 6 hours. So they had refractory hypoxemia or refractory hypercapnic acidosis, and you're having trouble keeping this patient alive on the ventilator. Control arm got standard of care ventilation. You could be proned, you can get all the therapies you want. And you can also cross over to ECMO for refractory hypoxemia, which we'll come back to. The intervention arm had VV ECMO inserted. And the primary outcome was 60-day mortality. This is a tough study to interpret here. we don't really know what to do with this. The mortality went from 46% in the ECMO arm to 35%, 46% in the non-ECMO arm to 35% in the ECMO arm. Did not meet significance, p-value was 0.07, but the trial was stopped early for futility since there was so much crossover from the control arm to the ECMO arm. Here, time on the x-axis, survival on the y-axis. ECMO group, early separation with more survival in red. Control group had less survival in blue, but once again, did not meet significance. This is tough to know what to do with. You can imagine if you're a provider taking care of a patient enrolled in this study, they're enrolled into the standard of care non-ECMO arm, and you watch her, SAT go from 88 to 85 to 82 to 78 to 75. And this is a young patient, their family's there. You can imagine at some point you're going to ask to have ECMO inserted, even if they're in the non-ECMO arm, to try to save their life. This is a rescue strategy. It's understandable there was a lot of crossover. The study did not provide a definitive answer on whether ECMO is a life-saving therapy for these patients, but we certainly use ECMO in the ICU when we have a patient with refractory hypoxemia or hypercapnia. We've exhausted all the strategies that we can do on the ventilator, and that we think they're a good candidate for ECMO, which is often a relatively young patient, not morbidly obese, with relatively few comorbidities or other organ failures. And if they can kind of check a lot of those boxes, that's a patient we think about putting on the circuit for ECMO. And then we get to the last one, the controversial one, steroids. So there are some conditions I talked about that are not ARDS that look like ARDS, cryptogenic organizing pneumonia. If you diagnose one of these conditions, a lot of these acute ILDs, organized pneumonia, eosinophilic pneumonia, hypersensitivity pneumonia, these are considered to be steroid responsive conditions. Absolutely, give steroids. For ARDS itself, this is controversial. There's been 4 studies pre-COVID that looked at this. The earliest one in 2006, the New England Journal, no change in mortality with steroids. A year later in CHEST, a smaller study, improved lung injury score and extubation by day 7 with steroids. Critical care in 2016, no change in mortality with steroids. And then this was published in COVID times, but the data is pre-COVID. This is the DEXA ARDS study in the Lancet Respiratory Medicine in 2020. Slightly larger study than the previous ones. Steroids improved 28-day ventilator-free days and 60-day mortality. So 2 positive studies, 2 negative studies with steroids. There was equipoise. I would say, including myself, most providers were not giving steroids for ARDS pre-COVID. And then you are all aware of the pandemic over the last few years. And sort of the biggest study published during that was the recovery study in 2021, which looked at dexamethasone for hospitalized patients with COVID out of the United Kingdom. So enrolled hospitalized COVID patients randomized to standard of care versus steroids. You're all familiar with this regimen, PO or IV dexamethasone, 6 milligrams a day for 10 days, with the steroid stopped early if discharged. Primary outcome mortality within 28 days. And it seemed to work. So it improved 28-day mortality for all patients. Not a massive benefit, but it cut mortality by about 3% absolute from 26 to 23%. The benefit was really for those who were on oxygen. So looking at the subgroups here, this first group, which was intubated at baseline, steroids cut mortality from 41 to 29%. So big benefit for intubated patients. You would think that a lot of these patients who are intubated with COVID have ARDS. The patients who were just on oxygen had a smaller but still significant benefit, which mirrored the benefits of the overall trial population from 26 to 23%. And the group that was not on oxygen had a trend towards harm with steroids, going from mortality of 14% with usual care to 18% with steroids. So overall beneficial, but really beneficial just in those who are on oxygen in enrollment, and really beneficial for those who are intubated and presumably have significant ARDS. So what do we do with this? For COVID ARDS, we give steroids. Our institution, and I'm guessing yours as well, has a pretty loose hand with the steroids once the patient is hypoxemic with COVID. For non-COVID ARDS, there's still equipoise. This study raises a question: are these patients different than our non-COVID ARDS patients? Should we be giving steroids for all ARDS? Most of us still don't. I do not. Most of my colleagues do not. But there is certainly equipoise here for whether you should give steroids for non-COVID ARDS, whether in the ICU or in the hospital wards. I'm hoping another large study is conducted for the non-COVID population to try to answer this definitively, whether we should give steroids for these patients. But as of now, it's sort of up to you. I think most providers give it for COVID and do not give steroids for non-COVID ARDS. So we'll wrap up here and go back to the case. We'll solve it and do some teaching points at the end. So this was a 23-year-old woman who was presenting to the emergency room with shortness of breath. She was afebrile, tachycardic, normotensive, tachypnic, and hypoxemic. She was in obvious respiratory distress. With your ABG on 100%, 50 liters of high flow nasal cannula, pH was 7.25, CO2 was 44, PO2 was 67. X-ray had significant bilateral infiltrates, as did her CAT scan with ground glass and consolidation. And the questions we wanted to answer for her are, what is this condition? At the moment, we don't know. It could be ARDS, but it could also be a mimicking condition of ARDS that could present in the same way. What caused it? If it's ARDS, it's most commonly from infection, although there are other etiologies of this. But she also could have heart failure, she could have alveolar hemorrhage, she could have an acute ILD, eosinophilic, organizing, hypersensitivity, interstitial pneumonitis, any of those. Workup, get an ABG. She's pretty sick, and we already had one that looked pretty bad. Microbiology studies, blood cultures, sputum cultures, urinalysis, COVID, and respiratory PCRs. Some sort of evaluation for heart failure, your exam, perhaps a BNP, at least a point-of-care ultrasound, and perhaps a formal echo. And then if you don't have an answer so far, think about a bronchoscopy, probably after she's intubated, looking for infection, alveolar hemorrhage, eosinophilic pneumonia. And if you still don't have an answer, think about a VATS biopsy to try to look for an acute interstitial lung disease that's mimicking ARDS. Your management probably needs intubation for hypoxemia and respiratory distress. And once she's intubated, low tidal volume ventilation, she's probably going to merit proning based on her hypoxemia. And if she's not in significant renal failure or shock, diuresis. So what actually happened to this patient? This is a patient, I changed some identifying details, but this is a patient I took care of when I was an intern back in the day and helped to spark my interest in the field I'm in now. She was intubated, had low tidal volumes applied, was prone for hypoxemia. Her workup was negative. This was pre-COVID, but we'll say her COVID was negative. Flu, blood, urine, sputum cultures were negative. She had a normal echo. We bronched her, and she had 42% eosinophils. And on further history from her family, she actually began smoking 2 weeks before admission. She was diagnosed with acute eosinophilic pneumonia, one of the most steroid-responsive conditions on earth. Eosinophils hate steroids. But she went from 100% FiO2 on the ventilator to extubated the next day. It's a very dramatic presentation for a condition that was really only diagnosable with bronchoscopy. She had no eosinophils in the peripheral blood, and that's usually the case with acute eosinophilic pneumonia, is you really need to keep investigating until you get a diagnosis. So we'll wrap up here, and then I can take any questions. If you think your patient has ARDS, you need to identify the cause of ARDS. ARDS is not really a final diagnosis. Like iron deficiency anemia, you need to come up with an etiology. If it's not ARDS, you can't find an answer, think is this a mimicking condition of ARDS, like diffuse alveolar hemorrhage. And if you can't find an explanation so far with your non-invasive tests, think about a bronchoscopy with bronchoalveolar lavage. And if you still don't have an answer, it won't be a lot of patients you do this to, but think about sending them for a VATS biopsy to diagnose something like organizing pneumonia that you're really only going to pick up with tissue. I once again maybe do this once a year where I send patients to our thoracic surgery colleagues, but sometimes it's the only way you're going to make a diagnosis. If they're intubated, always do low tidal volume ventilation. That's a mortality beneficial intervention and the foundation of respiratory management in the ICU. There's strong evidence for proning. There's a mortality benefit when they're intubated, and there is probably a benefit in decreasing intubation if they're not intubated. The other things we do, diuresis, steroids, ECMO, all have weaker evidence, but these are still things we do. Diuresis for most patients with ARDS, steroids especially for COVID ARDS, and then ECMO if they have refractory hypoxemia or hypercapnia. And as promised, I finished early, so I can take any questions.
Well, thank you so much. That was so informative. Take the first question as a chair. I'm really impressed with the fact that the ECMO seems to have one of the biggest discrepancies that I've seen in my career between what public, meaning our medical staff, opinion and the outcomes. Seems to be a big discrepancy. You probably all saw the ECMO CS presented in American Heart and published in Circulation for cardiogenic shock last month saying, no, it actually doesn't work. We should stop doing it. I don't know that that's definitive, obviously, for lung, but as you show, the evidence is marginal. Do you think that the trials are done wrong? Because everyone's opinion of it and the case anecdotally seem to be really that this saves lives. So what are you seeing that same discrepancy between data and practice?
Yeah, I think, the other trial that I didn't cite was a Caesar trial, which was, I'd say, not well conducted in that it took patients and took them, if they were enrolled in the ECMO arm, from a non-ECMO center to an ECMO center. So they had a number of other different therapies applied, including presumably better ventilation strategies at more specialized centers. I think the EOLIA study was well conducted, but with the caveat that you can imagine if that patient's in front of you, there's just such motivation to do something to save their life and cross them over to the ECMO arm. These patients on ECMO, they still die at a very high rate. These are the sickest patients we have in the MICU. So we still do it as providers. I don't know that it has mortality benefit. We had very tough outcomes with our COVID patients on ECMO, like a lot of institutions. But if you've got someone who they don't have a lot of comorbidities, they don't have a lot of organ failures, it's really just a lung problem and you can't oxygenate or ventilate them, I still refer them to ECMO, but I don't know if I'm saving their life when I do it. It feels like the right thing to do, but in critical care, we've been burned a lot over the last few decades for things that feel right, but turn out not to actually help the patient. So we still do it, but still an unanswered question.
Well, thanks for that. I'm going to turn it over to Dr. Saad, our division chief in pulmonary, and Dr. Gahar.
Thank you very much. It's a very nice overview. I agree that the proning is probably the most profound therapy that we know of right now for the ARDS, and we actually used it extensively during the COVID. We came up with some protocol for the proning because of this study results, of course, and we talked to our colleagues here, and we had kind of a strict criteria who goes in and who not, and we implemented, of course, all the rescue therapy, paralytics, and proning, and high PEEP, and all that before we consider, of course, the ECMO, and made sure that there is no organ failure like renal failure, and elderly patient also, they don't do very well with the ECMO. So we tried to be very selective with the ECMO, and I think it's working so far. We are very strict group of patients that ends up there, and I agree. The outcome is, in most of these patients, is not great because they are very sick. But that's the reality right now. I think we need to probably maybe look into the steroids, hopefully, and the non-COVID population, because I agree, it's kind of not really good data about that. But it's very difficult to do these studies because these studies actually needs a large number of patients and so on, and that's what's hindering us.
Yeah, absolutely. It's hard to enroll for critical care studies. I'm always jealous of our cardiology colleagues who have 10,000 patient studies. A big study in critical care might be 500 patients. So it's a tougher population to enroll. There's not a lot of pharmacy or drug company sponsorship for dexamethasone studies, but we need this data. These patients are dying at a high rate when they're intubated. So I'm hopeful, a group like the Pedal Network or someone like that will conduct this study for steroids for non-COVID ARDS, because we really do need that data. I agree.
Let me ask a question. Thank you, Dan. That was wonderful. I learned a lot. I was wondering if, I guess you can comment on the idea that maybe ARDS is an umbrella term, and there could be many different diseases underneath this term, which could explain why we have such different outcomes with different interventions. There's been a growing concern about different subphenotypes of ARDS based on the inflammatory markers. So if you could comment on that, and also the role of neuromuscular paralytics in the treatment of ARDS. And for our residents and perhaps fellows, the role of lung ultrasound in the management of these patients. Thank you.
Sure. All right, I got 11 minutes left. I think I can do this. So yeah, number one, subphenotypes, absolutely. So Carolyn Calfee has done a lot of this work out of UCSF. And ARDS is absolutely an umbrella term. It's a syndrome, first off, right, with lots of specific diagnoses underneath. And this has been broken down largely into probably two subphenotypes, like you mentioned. One is a more hyper-inflammatory phenotype, and one is a hypo-inflammatory phenotype. They have different outcomes and may have different responses to therapy. We don't yet have the ability to sort of separate those groups early on during clinical care and figure out whether the patient is in one subphenotype versus another, and whether that patient merits different therapies in terms of steroids or Pronine than the other group. That's coming, though. That's probably coming in the next 5-10 years, where we'll hopefully have either point of care or relatively early data to say this is a patient with this type of ARDS and should be managed with these therapies. And we'll stop thinking of all these patients as the same. Critical care does not have the, I'll once again use cardiology as kind of our shining star here. We do not have the specificity yet to really delineate these patients into subgroups the way that our colleagues in cardiology do. So we're kind of a little behind in precision medicine, but we're catching up. Studies are being conducted, and I think in the next 5-10 years, we're going to be able to really break these patients down into groups that get different treatment strategies. All right, that was number one. I know number 3 was ultrasound. What was number 2?
Neuromuscular paralytics.
Thank you. Yeah. So actually, I deleted those slides from this talk since I know it was a broader audience. But yeah, paralytics. So the Acurisa study, which took place, I think when I was an intern, looked at paralyzing patients for the first couple of days for early severe ARDS, and showed a borderline mortality benefit really only after they adjusted for baseline characteristics. But as an easy therapy to apply, your patient's very easy to manage on the ventilator when they're paralyzed. So we had a very loose hand with paralytics early on for the first few years. And then the ROSE study, published a couple of years ago, was conducted here by the Pedal Network. Same inclusion criteria, same paralytic protocol, and really showed no benefit at all of paralytics. As for why there was a different result, the Acurisa study could have been a false positive. It was sort of a borderline mortality benefit. The ROSE study also was unblinded, whereas Acurisa was blinded. Since Acurisa was blinded, both the paralytic arm and the non-paralytic arm were deeply sedated. Deep sedation is sort of a necessary evil. So if you don't have to do it, don't do it, because it harms your patients, it keeps them on the ventilator longer. The ROSE study was unblinded. So the paralytic arm was deeply sedated since they were paralyzed, but the non-paralytic arm could be lightly sedated and thus presumably wake up earlier, get off the ventilator earlier, and live more. So that's maybe why there was a difference between the two. Takeaway, I no longer routinely paralyze my patients, even with severe ARDS. I really only paralyze them if I'm sort of at the end of the road before ECMO. They're refractory hypoxemia or hypercapnia, or they have severe ventilator dysynchrony that cannot be managed by sedation or changes in the ventilator settings like tidal volume, respiratory rate, et cetera. So we generally don't routinely paralyze anymore. It certainly exists in our armamentarium as a rescue strategy. Right around the time you're reaching for EPO or NO or whatever you use there for refractory hypoxemia, that's about the time we're reaching for paralytics. And after that, you're reaching for the phone to call the ECMO team because you're sort of at the end of the road. And then ultrasound, absolutely, wide use in the ICU for a number of conditions: cardiac, pulmonary, DVT, abdominal. For ARDS, there's plenty of data that you can diagnose ARDS and diagnose those bilateral infiltrates with ultrasound. Ultrasound won't tell you really whether it's ground glass or consolidation, but it'll show what looks like a consolidation on ultrasound. You can certainly pick up how many lung zones have ultrasound findings, and you can diagnose those bilateral findings with ultrasound. You can diagnose concurrent conditions with pleural effusions. You can diagnose pneumothoraces, and you can diagnose heart failure that may mimic ARDS. We use it a lot in our ICU, although, I mean, honestly, most of these patients who are sick enough to be intubated with me, they all have x-rays, and most of them end up getting a CAT scan. Although, as I talked about, a CAT scan itself is not going to generally differentiate between ARDS, eosinophilic pneumonia, organizing pneumonia. Ultrasound won't make that differentiation either, but ultrasound can actually give you a bedside way to diagnose those bilateral opacities without sending the patient to a CAT scan for an unstable patient.
All right, we do have one question in the chat area. This is from Dr. Abhyankar, one of our residents, and she wants to know: is there They want, is there a difference in outcomes on ECMO based on etiology?
Probably. I don't know any particular studies to cite here. I'd say COVID patients tend to not do great, but I don't have specific numbers for you. Like someone else said, perhaps Dr. Williams, if these patients are really sick before you put them on ECMO, they're still going to be really sick when you put them on ECMO. So if you take a patient with, terrible hypoxemia, terrible multi-organ failure, and you put that patient on ECMO, there's still a very good chance they're going to die on ECMO. It might now take a month to die instead of a day to die, but there's still a very good chance they're going to die. If you put a healthier patient on ECMO, single organ failure with the lungs, not as much hypoxemia, hypercapnia, comorbidities, younger, that patient's going to do better with ECMO. So ECMO is not a panacea. You're still going to have poor outcomes if you put sicker patients there. So I'm rambling. I don't know specific numbers to cite here, but the sicker the patient off ECMO, still be the sicker patient on ECMO and more likely to die.
So that's a good perspective. Dr. Emmons has a question. If there are any evidence for any specific cytokines that might be blocked in order to optimize outcomes in ARDS as we do for cytokine storm disorders.
Yeah, I mean, obviously, you guys, know the COVID, there was evidence for tocilizumab, IL-6 inhibitor, baricitinib, a JAK inhibitor. So we're sort of a baricitinib institution, so we use that along with steroids. In non-COVID patients, not really. This was studied, off the top of my head, anakinra was studied decades ago for these patients and did not show benefit. I don't know of any therapies that have shown benefit in the non-COVID ARDS population for a specific cytokine blockade. Steroids obviously have a very wide effect on a number of cytokines. But really, most of the data we have is from COVID ARDS. And most of us, when the patient gets very sick and hypoxemic, our regimen here is a combination of remdesivir, dexamethasone, and baricitinib. Your institution may use that. You may use tocilizumab. You may decide the data is not strong enough for either cytokine blockade. But we don't have a lot of similar strong data outside the COVID population.
Fantastic. Jason, that's all I'm seeing. Well, actually, the follow-up question.
Yeah, Dr. Emmons had one more, little follow-up.
Yes, indeed. What about early ARDS? I guess it's the same question. But
Dr. Emmons, do you want to unmute or maybe tell what you mean by that?
Sure. So there are phases of pathophysiology in ARDS. You mentioned the early phase patients who haven't gone into such significant organ damage yet. That's when the cytokine storm may make a bigger difference. Is there any evidence that it makes any difference earlier in the course, or is that just such a difficult thing to study that we have no idea?
Yeah, it's tough. Once again, I'm going to kind of cite COVID data, although it's not entirely clear those are the same populations. The idea behind why steroids worked, in the specific subpopulations it did for COVID patients is maybe early on, there is increased viral replication. You don't want to immunosuppress them. Later on, it's more an inflammatory cascade, and you want to immunosuppress them. Early ARDS, I don't know of any data suggesting that steroids work better for that early population. Of the studies that I cited for the non-COVID population, there are 4. The initial New England Journal study that was negative was more persistent ARDS. Patients had ARDS for much longer, and steroids did not show a benefit. Some of the other smaller studies that showed benefit were for earlier ARDS. But this is definitely not a question that has been definitively answered. We really need just a large 500,000 patient study for patients with early ARDS in the first couple of days of their presentation to the hospital, getting steroids or not. Does it help them for non-COVID ARDS? And we do not have that data. As far as I know, you would certainly think that once a patient's been on the ventilator for 2-3 weeks, there's not a whole lot you can do to help that patient at that point. So it's probably beyond the limits of a lot of our medical or other interventions.
One last thing, if we've got just a moment, is that in kids who undergo bad respiratory problems, the lining of lipids along the epithelium of the lung is disordered. Is there any evidence that that lipid lining issue makes any difference in adult ARDS? And has anybody ever looked at interventions in that way?
Nothing that I know of for adults.
Thanks.
Looks like we have one last question. Dr. Brar is asking, do you think esophageal balloon will become more common to determine PEEP in it really should be ARDS?
Yeah, the esophageal balloon is just what sounds like a balloon you put in the esophagus that gives you a proxy of pleural pressure. So sort of all the rage 5-10 years ago, the EP-Vent1 study showed possible mortality benefit from it. But a follow-up, the EP-Vent2, which looked at using the esophageal balloon to kind of set your PEEP and set your tidal volumes, very large multi-center study, showed absolutely no benefit from it. So I think it's somewhat fallen out of favor. You think it provides an elegant way to determine their pleural pressure and thus determine their transpulmonary pressure, the pressure across the lungs from inside the lungs to outside the lungs. We think it'll be a more elegant way to set our ventilator, but it really has not borne out in the data. So we don't use it here. I don't think a lot of providers use it. There's a lot of cumbersome aspects to its use and some false data you can get if it's not properly positioned. So it's still sort of a therapy waiting for data to support its use.
Indeed. Well, this has been really an amazing encyclopedic review of ARDS and all of the things that we should be thinking about. I really appreciate the comprehensive nature of what we've discussed today. And we will, before we discharge everybody so that you and I do the Cardinal Minute, I do want to mention to everyone that we will be off for the next 2 weeks, and we will start up again on January 5th with Dr. Kaura speaking from cardiology for our grand rounds. And so I'm wishing everyone a happy holiday season. Hope that you take some time with your families and recharge and come back strong. Motivated to know that our grand rounds is full of fantastic information like this one was. And so happy holidays, everyone.
Thanks, everyone. And real quick, we have a little quick presentation, a gift for Dr. Kelmenson. A little tradition here with the UofL Department of Medicine Grand Rounds. We have that we've continued even through the virtual world, that a little gift for our guest speakers, and it's something very synonymous with Louisville. So you will be getting your very own Louisville Slugger bat.
Wow, I will keep that far away from my 2 young boys, but I very much appreciate the gift. Thank you.
Thank you. And we thank everybody, and we'll see happy holidays, and we'll see you next year.